Hello everybody, welcome to radiology. In our first lesson, let's learn about one of the most frequently requested radiological investigations, that is chest X-ray. Before understanding pathology, we should appreciate the normal chest X-ray. Here we will mainly focus on posterior anterior projection. To assess the chest X-ray, we should go through these things: the details, quality, main areas of concern, and then the review areas or the hidden areas. Let's go through one by one. The details. The patient identification is important. So the name, age and patient details should be printed. Then date and time. Study number should be printed. And then the type. This is a PHS X-ray. So it should be mentioned. Sometimes it can be supine, lateral or decubitus. And that should be mentioned. Then usually the right side is marked in the chest X-ray. The quality given by the mnemonic right. R for rotation. There should be no rotation. How to assess that? That is assessed by measuring the distance from the spinous process to the medial ends of the clavicles. This should be equal on either side. Then the chest X-ray is well centered or not rotated. This is measured usually at T4 level. Then the inspiration. If the inspiration is adequate, we will be able to see 5 to 7 anterior ribs or 8 to 10 posterior ribs above the diaphragm. 1, 2, 3, 4, 5, 6 anterior ribs. And then 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 posteriorly. So the inspiration is adequate. Then P for projection. This is a PA chest X-ray. In a PA chest X-ray, the lung fields are clearly visible because the scapulae are widely apart, not covering the lung fields. We are focusing on the PA chest X-ray in this lesson. Then the exposure or penetration. If it is adequately exposed, we will be able to barely visualize the intervertebral discs through the heart shadow and also the spine. Spine and intervertebral discs should not be very clearly visualized. Then the upper thoracic spinous processes will be clearly seen. This is D4. And left hemidiaphragm is also clearly visualized up to the spine. The lung markings can be traced up to the periphery of the lung. If the exposure is less, then the chest X-ray will be white than the normal X-ray. If the exposure is more or over-penetrated, then the X-ray will be darker than normal and the details will be less clear. Here is how the posterior anterior chest X-ray is taken. The X-ray beam travels from posterior body to the anterior body. The patient is standing and the anterior chest is placed against the front of the X-ray film, and then the shoulders are rotated so the scapulae are widely apart and taken in the full inspiration. The PA projection is better than the AP projection because there is no magnification of the structures such as heart and the mediastinum. Therefore, heart size can be accurately assessed and also the images are more sharp. In AP, the margins are not sharp as in the PA projection and the heart appears larger than the normal. Let's go to the detailed assessment of the chest X-ray. There are various approaches. I will use the inside out approach, inside to out. So we will look for trachea, then the hilar structures, the heart and the rest of the mediastinum, then the lungs, then the pleura, diaphragm, and rest of the structures, chest wall, soft tissues and bony structures. First, the trachea. usually central and can be slightly deviated to the right side due to the aortic arch. And it divides inferior to the main bronchi, where there is an angle in between called carina, or the carinal angle, which is about 60 degrees. This angle can be widened by various pathologies like left atrial enlargement. And there is a thin white line delineated by the gas on either side. That is called the right paratracheal stripe, extending from the clavicle to the esophagus vein. It is usually less than 3 mm and can be thickened by the adjacent pathology like lymphadenopathy or mass. Then the hilar structures made by pulmonary vasculature and the main bronchi. The position, size, angle and density of the hilar are important. The left hilum is slightly higher than the right hilum, but not always. And both hilar are more or less of similar size. Then the hilar angle made by the superior pulmonary vein and the descending pulmonary artery, it is about 120 degrees. This is the hilar point. And the density is more or less of the vascular density. Position, size, angle and density can be changed due to the pathologies adjacent to the hilar. For example, hilar angle can be obliterated by lymph nodes or mass, and the density also can be increased due to same reason, and size also can be increased. The position of the hilum can also change because of various pathologies. Significant change in the hilar position can be due to lung collapse, which can be secondary to a mass compressing the bronchi. Then the heart. The heart size is important. That is measured by cardiothoracic ratio. The heart size is assessed using the most lateral points of the heart and taking the distance from one right side lateral point to the left side lateral point. Then the thoracic measurement is taken at the widest point of the inner aspects of the rib cage. The ratio should not be more than 50%. If it is more than 50%, it is abnormal and considered as cardiomegaly in a proper posterior anterior chest X-ray. This measurement is not accurate in AP view because of the magnification. And this can change if there is any rotation. So, in a good quality chest X-ray, the cardiothoracic ratio, if it is more than 50%, we consider it as cardiomegaly. And the heart position is more towards the left side, about 2/3, and to the right side, about 1/3. Then heart border. Right heart border is made by the right atrium, left heart border by the left ventricle and the left atrial appendage. The inferior heart border is not completely visualized. Then the mediastinum is the ascending aorta, aortic arch, descending aorta, and then the left pulmonary artery. So ascending aorta, aortic knuckle, between the aortic knuckle and the left pulmonary artery, aortic pulmonary window, and descending aorta. These mediastinal contours or margins can be deviated or obscured by various pathologies. For example, lymph node here will obscure the aortopulmonary window, and certain pathologies can displace or deviate the mediastinal contours, such as aortic aneurysm can displace the margin of the aorta, and adjacent lung pathologies can obscure the mediastinal margins. For example, consolidation. Then one important line is the azygoesophageal line, extending from the azygous venous arch and inferiorly down to the aortic hiatus. This is delineated by the right lower posteromedial lung segments and esophagus as well as the azygous vein. Deviation of this line can be due to various pathologies such as hiatal hernia, esophageal pathology, left atrial enlargement, and subcarinal lymphadenopathy as well as bronchogenic cyst. But there are certain variations also, especially in the children. Then the mediastinal compartments. These are usually visualized in the lateral chest X-ray. Superior, anterior, middle and posterior mediastinal component. Superior mediastinum is above the pericardium. Anterior is anterior to the pericardium. Middle is within the pericardium and posterior is posterior to the pericardium. And superior mediastinum also is above the plane of Ludwig, that is from the sternal angle to the inferior end plate of the T4 vertebra. This is important to localize various pathologies. For example, certain pathologies may occur in the superior mediastinum. The retrosternal space and the retrocardiac space here are of similar low density. That is also important factor. Sometimes certain pathologies can obliterate this low density areas. Then to localize the pathologies, we divide the lungs into three planes, three zones: upper zone, mid zone and lower zone. We should compare right side and left side. Right upper zone, left upper zone, right middle zone, left middle zone, and right lower zone, left lower zone. These are not comparable with the lung lobes. These are different from the lung lobes, and the lower zone extend below the level of the diaphragm. Usually the upper two intercostal spaces are included in the upper zone, then the next two intercostal spaces included in the middle zone. We should look for the symmetry. The asymmetry can be due to anatomical normal structures, like the heart is more towards the left side. And sometimes it could be due to technical factors like rotation. And also the asymmetry can be due to lung pathology like consolidation, mass. In the lateral image, we may be able to see the oblique fissure. In the right lung, there are three lobes, upper, middle and lower lobe, and there is horizontal fissure and oblique fissure. In the left lung, only the oblique fissure is there, so there will be two lobes, upper lobe and the lower lobe. The horizontal fissure is usually seen in the frontal projection, and oblique fissure can be seen in the lateral projection. Then we will move on to the pleura. Usually the normal pleura is not clearly visible. When it is abnormal, for example, pneumothorax, pleural thickening and effusion, we can see the pleura because of the pathology. Then the costophrenic angles and the diaphragmatic margins are usually clearly seen. These can be obscured by pleural effusion. Usually the lung markings extend up to the periphery of the lung, up to the chest wall. But in pathologies like pneumothorax, the lung markings will not be extending up to the thoracic wall. So when we see that, we will suspect that there can be a pleural pathology widening the pleural space. So we look for pneumothorax. Then the diaphragm. Right hemidiaphragm is usually higher than the left hemidiaphragm, and just below the left hemidiaphragm will be the gastric air bubble. And the right hemidiaphragm, in the lateral X-ray we can clearly see throughout, but the left hemidiaphragm is obscured below the heart cavity. Therefore, we can identify the right and left hemidiaphragm separately in this lateral view. And the stomach will be immediately below the left hemidiaphragm. Usually the right hemidiaphragm is little higher than the left hemidiaphragm due to the liver. Then we can measure the height of the dome from the osteophrenic angle to the cardiophrenic angle, and then this line is along the highest point of the dome. This should be at least 1.5 centimeter. If it is less than that, we consider as diaphragmatic flattening. It can be due to tension pneumothorax or emphysema. Therefore, the diaphragmatic dome height is also important. Then the rest of the things, the chest wall, soft tissues, and the bones. In the soft tissues, it is important to assess the symmetry, whether there is any swelling, any gas, and masses. In a trauma patient, there can be subcutaneous emphysema. There can be calcification due to various reasons, and we should assess the breast shadows. Sometimes one breast shadow can be absent in previous mastectomy, and the nipple shadows can be confused with lung pathologies, lung nodules. Then we can assess the bones, the ribs, clavicle, the scapula, humerus, and the vertebral column, sternum. And there can be destruction of these bony structures, lytic and sclerotic lesions, fractures, and we should assess the density of the bony structures. There can be dislocation, so we can assess the bony structures. This is a very important sign, the silhouette sign. The meaning is loss of normal border between structures of different radiographic densities. So the gas is lower density, the heart is higher density, and therefore the border should be sharply seen. But if it is obscured, if it is lost, then we suspect whether there is a pathology in the adjacent structure. For example, lung consolidation, consolidation will obscure the left heart border, and right heart border can be obscured by right middle lobe pathology like right middle lobe consolidation. And also the diaphragmatic margins can be obscured by pleural effusion and likewise. So when the density of these two structures are different, the margin is usually sharply seen. When the pathology is not clearly identified, but if there is a obscuring of the margin in between the structures, then we suspect there can be a pathology even though the pathology is not clearly seen. So that is the importance of silhouette sign. Then finally the review areas or the hidden areas. The pathologies in these areas can be overlooked or easily missed. So we have to review these areas after the initial assessment. So the abscesses. There can be certain pathologies, masses, sometimes rib destruction. Sometimes rib destruction can occur due to Pancoast tumor. So we will look at the abscesses well to see any hidden pathologies. And then the retrocardiac space. There can be consolidation, collapse behind the heart that will be obscured by the heart shed. And then the subdiaphragmatic space. Left side there is gastric bubble. If the gastric bubble is not seen in a frontal upright chest X-ray, then we can suspect various pathologies. And there can be gas beneath the diaphragm in pneumoperitoneum. Then the phylum also should be assessed carefully. This is another approach. We use the inside out approach, but there are other approaches like ABCD, AEF, GH approach. You can use any approach that is convenient for you. So I will just summarize the ABCD, EF, GH approach. A for airway, then the bones, C for cardiac and the mediastinal structures, E for effusions for the pleura, F for fields, lung fields, G for gastric bubble, and H for hive. So you should use whatever the convenient method to assess the entire chest X-ray, and you should use repeatedly the same method. Then you will be easily able to interpret a chest X-ray, and then you can gather most of the information out of the chest X-ray. Thank you, and I hope you have learned something about the normal chest X-ray interpretation. Have a good day.